Welcome to RUMC Vital Signs. My name is Alex Lutz. On our show, you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit www.rumcsi.org. Surgery, by definition, is a medical procedure by which a doctor can repair, remove, or replace a diseased or damaged body part, usually involving an incision. And while this may sound disturbing and a little frightening, advances in surgical techniques and technology are greatly reducing pain, scarring, recovery time, and the risk of infection, resulting in better patient outcomes. Joining me today to talk about modern surgery performed right here on Staten Island at RUMC is the Chair of Surgery, Dr. Loren Harris. Thank you for joining me.
Thank you.
Dr. Harris, tell us a little bit about what are some of the most recent advances in surgery that have helped shape the profession in recent years.
Well, I think probably the most recent development in surgery is the development of minimally invasive surgery, and that's changed over the years. We've gone from laparoscopic and so-called thoracoscopic in the chest procedures to the cutting-edge procedures that we now do with robotics. And contrary to what people may believe, robotics is not surgery done by a robot. It's surgery done by a surgeon and a team of support staff in the operating room using robotic technology. And that technology allows us better vision, 3D vision inside the abdomen, inside the chest, as well as much higher precision dissection of structures and the actual performance of the operation. And what this allows for is we can do the same procedures we used to do open and laparoscopically using robotics with much higher precision and much lower levels of pain, so that patients can return to their normal life much quicker, with shorter lengths of stay, and much higher satisfaction.
And what are some of the procedures that you're performing at RUMC using the robotics?
Well, I mean, I think the list is probably shorter if we list the procedures we're not doing robotically. Basically, it goes across the spectrum of surgery, from gynecologic to general surgery, urology, ear, nose, and throat surgery. All those are being done robotically. My specialty is general thoracic surgery, and we're essentially doing every procedure robotically. Wow. And we found it to be a great benefit to all of our patients.
You talked about the benefits of the patients, but what is the benefit to you as the surgeon using a robotic system?
Well, I think that the visualization of the structures that we're working around and working to take out or mend is greatly improved. It's three-dimensional. When you're working on the robot, you're looking at the structures in 3D. And so that is of great benefit. The dissection is much more precise. You can see and use the actual tissue planes that essentially you were doing when you were doing open surgery, except now you're doing it with an instrument that's this big. The functional portion of the instrument is that big. That's what's actually inside the patient. So it's much less invasive and every bit as precise as doing these procedures the way we used to many, many years ago, using much larger incisions.
So obviously robotics was not around when you first began your career.
Correct.
So when talk about the training that goes into learning how to use a robotic system.
Sure. I mean, the training is pretty arduous. You have to be board certified. You have to have full privileges at the hospital, and you have to have, from beyond that, you have to have specific training in robotics. And there are certain steps that are required not only by the company that makes the robot, but also by the hospital as well, to make sure that anybody doing robotics procedures is fully trained and competent. And we have a specific robotics committee that goes beyond standard surgical privileging to address the idea of robotics privileges.
So when robotics first came on the scene, was this something that was embraced by the surgical community, or is it one of those things where kind of like don't want to be the first one in the pool?
Yeah. Well, you know, it's funny because there's never been an advance in medicine that wasn't made by a heretic. So when robotics first came on the scene, there were a lot of naysayers. And most of those people are on the other side now. And that's kind of the way it should be. Anytime there's a new technology or a new medicine for a disease, we shouldn't just jump in. We should wait and see, is this safe and is this effective? And those are two separate questions. So when robotics first came on the scene, and it was several iterations of robot behind what we're using now. It was, I think, healthy for people to say, is this better than what we're doing? And eventually, we saw that that it was. That procedures that everybody said, oh, there's no way you can do this robotically, were actually being done robotically and being done safely. And then not only, so we proved that it could be done safely, but then we showed that the results were as good or even better than doing it the other ways, whether it's open or laparoscopic, thoracoscopic ways. So not everybody has converted to robotics, but if you look over the last 10 years, the percentage of procedures being done robotically has increased almost logarithmically.
And talk a little bit about the system that we're using at RUMC.
Well, we're using the intuitive surgical system, which is really the only true system that's out there for robotics, and their most recent iteration of the robot is extremely surgeon and nurse friendly. It's very, very safe, and it's an amazing system for doing this. And there's so many safeguards built into the robot that it's very hard to do something dangerous. The robot stops you, or with your training, you learn how to do things that are safe for the patient, because that's ultimately our final concern, is that things are being done safely. But it's an amazing system, and almost anybody can go on YouTube or any other site and look at these videos of how these things are being done. It's extraordinary.
From a patient standpoint, when you're talking to someone that you're going to be robotically operating on, do you encounter a hesitancy? How do you explain to them that you're working, it's robotic, but you're going to be safe, you're going to be okay?
Yeah. Ironically, I don't encounter that hesitancy, because most people have heard of it, and many of my patients, by the time they come to my office, they've already Googled a lot of this thing. And
Dr. Google.
Yeah, and they've watched videos. They know what's out there, and they'll actually ask me questions as though they've actually done the procedures themselves. Are you going to do it this way, or are you going to do it that way? And it's actually leads to a much more satisfying conversation with the patients. But I make sure that they understand that it will be done robotically, and I tell them exactly how that's done, how many incisions we're going to make, what the size of the incisions is, and of course guide them through the post-operative care. If they're going to have a drain, what kind of drain, when the drains are going to come out, what they're going to experience. So patients don't like to be surprised, and the only people who like to be surprised less than the patients are the surgeons. But people don't like to not know what that next morning is going to be like. So it's important that you have that conversation with them.
Do you encounter situations where you expect to go in robotically and then realize you have to go to general surgical procedure?
There is a conversion rate that's published out there. It's very unusual to have to do so, but there is always a chance, and you have to tell them that before the surgery. There's always a chance, anytime you're working, certainly in the chest, around major vascular and life-sustaining structures, that something can possibly go wrong, that would require us to make a bigger incision and go in and do it the old-fashioned way. The good news is that's extremely unusual.
That's good. So as the chair of surgery, when you are recruiting the next wave of surgeons, do you look for that robotic training in a CV and a resume before you offer a job?
Yes, absolutely. And having a robust robotic program actually allows us to attract those highly trained and robotically inclined surgeons. And I think that that's a good thing. It helps bring a higher level of care to Staten Island. The surgical training programs are starting to understand that and starting to emphasize robotic training, so that even the surgical residents are facile in robotic techniques and are ready when they go forward to start doing those cases.
So the majority of the surgical staff at RUMC are robotically trained?
Yes.
And what are some of the procedures where robotics may not be used? You said there's a shorter list than the other one. What are some situations?
I think that, and that list keeps shrinking every day, because, for example, we used to say if someone had a previous operation, you can't do it robotically. Well, it actually turns out now that previous surgery is actually, a standard indication to do it robotically. So things are changing, and most of the time the decision not to do it robotically or minimally invasively is really depending on the patient. Some patients are just better treated with an open operation, depending on the disease you're talking about, or their body habitus, or their other comorbidities. But that list is getting much shorter, almost by the day.
And with the technology constantly changing, and just, I'm imagining the surgical field changing so frequently, how do you and your colleagues stay up on the latest techniques, the latest trainings?
Well, I think that, certainly keeping up with your own literature. I keep up with the general thoracic literature, the general surgeons with the general surgery literature. That's critically important, because a lot of that new technology and new techniques type of information appears in the literature. So that's something that doctors have been doing for 100 years. But also, the social media, things like YouTube, and going to meetings. You talk with your colleagues at different institutions, and they might present a paper on a certain procedure that you didn't even think was feasible. And you say, wow, this is great, and look at these results. And so now you're going to start to do it that way.
Gotcha. And how long have you been a surgeon for? How long?
Oh, I finished my fellowship in 1996, so about 25 years.
Okay. So walk us through kind of your game day, your game day preparation. So every patient, I'm sure, is different. It may look the same on paper, but it's different. What do you do the night before, morning? How do you get your game face on?
Well, you're right. No two patients are the same, even if they have the same quote-unquote disease. No two patients are the same. So I review their chart, all their comorbidities, their medications, to make sure that we're at least prepared from that standpoint. I know what the disease is, who the patient is, and what medications they're taking that might affect how we do something. I always, now that social media is so prevalent, I have a standard set of videos that I review the night before. For example, if it's a cancer in the right upper lobe and I'm going to do a right upper lobe removal or right upper lobectomy, I have standard 2 or 3 videos that I will watch, and watch the steps over and over again, review the anatomy. And I think that's critically important, because you always have to be ready for that abnormal anatomy that happens in 1 or 2 people in 100. But when you see it, you better be able to recognize it and deal with it. So and there is a preparation. People talk about football players preparing for the Super Bowl. Well, every operation we do is the Super Bowl, because that you only get really one shot at doing it right. So you want to make sure that you're ready to do it.
And I know in the next couple of weeks, you're going to have a brand new surgical department, which we're going to talk about after we take a quick break. We're actually going to switch now to, as we take a break and prepare for the next part of our show, we're going to show a quick video that explains more about robotic surgery and the procedures and the machinery that we're using at Richmond University Medical Center.
Whether you or someone you love is preparing for robotic-assisted surgery with Intuitive's Da Vinci surgical system, it's helpful to know what to expect. This video will give you an overview of your surgery day. We'll also cover some background on what a robotic surgical system is and how it's used during surgery. First, let's focus on the pre-surgery process. Once you check in, your care team will begin to prepare you for surgery. Your surgeon and other members of your care team will review your procedure with you and answer any questions you might have. When it's time for surgery, you'll be brought into the operating room, joining your surgeon and members of your care team. The Da Vinci robotic surgical system will also be in the OR before your surgery begins. You'll receive medicine to help ensure you don't feel any pain. During the procedure, your surgeon will stay with you in the room and control the robotic system to perform the robotic-assisted procedure. What's nice about the robotic-assisted surgery is that it's a minimally invasive option, so the surgeon works through small cuts in your skin called incisions. They range in size from 8 to 13 millimeters, which is about the size of your fingertip. Through these openings, your surgeon will perform the surgery using a camera and long, thin instruments. You could think of Da Vinci systems as technology tools that enhance your surgeon's capabilities. For example, the camera allows the surgeon to see the surgical field in 3D and magnified to 10 times its normal size, so they can see details more clearly than with the naked eye. It would be like looking at a quarter the size of a dinner plate. During the surgery, your surgeon will use instruments that move like a human hand, but with a greater range of motion. The system's built-in tremor filtration technology helps your surgeon move each instrument with smooth precision. When surgery is complete, your surgeon will close any small incisions with a few tiny stitches. The care team then moves you from the operating room to a recovery room. You'll stay in the recovery room until you wake up. Before you have surgery, your care team will let you know how long they expect you to stay in the hospital. Once your surgery is complete, you're joining patients from around the world who've collectively undergone millions of robotic-assisted surgeries with Da Vinci systems.
Later this year, Richmond University Medical Center will unveil its new state-of-the-art surgical department. Located directly above the hospital's new emergency department, which opened in January of this year, the new surgical department is a dream come true for not just patients, but the hospital's surgical team as well. Here to share details of this new $41.2 million department is President and Chief Executive Officer of Richmond University Medical Center, Dr. Daniel J. Messina. Welcome, Dr. Messina.
Thank you. Great to be here.
So tell everyone about some of the features that they're going to see inside this new surgical department.
So we're very excited, looking at 10 spacious new surgical suites, 6 general suites, 4 specialty suites, 3 of which will be robotically prepared, so we'll be able to really bring all the latest advances to the surgical team.
Mm-hmm. And why was it important for you, the executive leadership and the Board of Trustees, to invest in a new surgical department?
Well, the evolution of hospitals have now kind of reached a point where it's high acuity medicine in hospitals. So our investments really centered around emergency medicine, high-end surgery, and critical care. So each of our investments over the last few years have been targeted to those specialty areas.
Mm-hmm. And Dr. Harris, it must be like a kid in a candy store. You have a new surgical department coming for you and your team. So when you first heard about this, what were some of the things you wanted included in there and the input from your team in the development of this new department?
Well, I think that the surgical suites needed to be state of the art, and they needed to be larger than the ones we're working in now. They needed to have the most advanced equipment and allow for surgeons, nurses, and ancillary staff to do their jobs with the highest degree of efficiency and safety for the patients. And I think we've achieved all of those goals. The operating rooms are not only beautiful to look at, but they're highly functional, very efficient, and have the best technology out there.
Was there anything or any specific things you really wanted for this department as it was being developed, or you felt was needed for it to function?
Well, I mean, I think that it needed to be, like I said, you know, it's the technology, the lighting, the beds, all the way down to the electrical circuitry that we use, because as you can imagine, the technology used in today's operating rooms goes well beyond anything most people can even imagine. So all that needs to be powered and be able to be used and get in and out with the highest degree of efficiency, because that's what makes modern ORs run.
And Dr. Messina, how critical is it that the new surgical department is located directly above the new emergency department?
Well, that just creates incredible, you know, improvements in workflow and patient care by having the surgical capability immediately above the trauma department, which is part of our emergency department, of course. So that is really going to be a major step forward. We also, in the surgical department, the new surgical department, we have just, it's been designed by surgeons, by nurses, by all the people who will use this new space. So workflow has really been optimized, as well as infection control. We just have some great design features that will truly take our surgical infection control commitment to new and expanded levels. This is truly a world-class surgical department.
And it takes into account not just the patients, but obviously their families as well.
So there'll be great support space for our patients, for our families, for our surgeons. We've introduced natural light in one of the corridors. So oftentimes in surgery, in the surgical suites, it's a pretty confined space. This really takes some great features and brings natural light, which will be great for our staff.
And RUMC is a community hospital with a great history of serving Staten Island. There's a lot of great people who continue to work there, and I understand that there's already an honor being bestowed on a longtime part of the faculty for RUMC. If you want to tell us a little bit about that.
Sure. So, you know, one of the key elements of the surgical department will be 23 post-anesthesia recovery units, PACU beds. And they will be named after Dr. Carpenito, who is a long-standing member of the medical staff of the hospital, chair of anesthesia, and our executive vice president.
So this surgical department is just the latest milestone at RUMC. If you could talk a little bit about some of the things that have happened in the recent months, the improvements that are made at RUMC, and also what's coming up in the next couple of months and years that the public can expect.
So we are in the middle of a $300 million expansion and renovation process. It kind of all came together. Last August, we opened up our new critical care unit, which is a beautiful 14-bed, state-of-the-art, high-end, beautiful critical care unit with lots of space, family space, pull-out sofas, beautiful full-service bathrooms, and video technology to do video consultations, built-in Hoyer lifts, all types of technology, double head walls, which allows for us to expand in a disaster situation, doubling the capacity from in the medical ICU from 14 to 28. During COVID, we actually went from 26 critical care beds to 71. So we are really thinking about the future and all the lessons learned over the last couple of years. So also recently we did a major renovation of our exterior facade, replacing some 700 windows. That was a $45 million project. Our new medical ICU that I just discussed. We're in the middle of completing a new energy plant that will allow us to come off the grid, called cogeneration. And that is something that's being wrapped up over the next couple of months. And then, of course, the new emergency department, which is really the front door to the hospital. And soon to be, we expect in late fall, the new surgical department. But backing up all these great new programs are a list of other strategies and projects that will unfold over the next period of time. That'll include a new surgical ICU, pediatric ICU, neonatal ICU, as well as several other projects and expansion of our beautiful new cardiovascular center. That's actually in the works. That is going to be starting over the next couple of months. So lots of great advances and steps forward, building on the rich history of Richmond University Medical Center, some 120-year-old institution that is really transforming itself and doing some great things for the community. I would be remiss if I didn't thank our elected officials and our fabulous medical staff for their support, and great things are ahead, so we're excited.
And so, Dr. Harris, you talked earlier in the episode about the talented staff, and it sounds like now the facilities are matching the talent that you have on your staff.
Yeah, no, we couldn't be more excited, and we're hiring new surgeons to take over for in various areas that are in great need on Staten Island. A surgical oncologist. We're going to expand our head and neck division to handle bigger cases, and we have all the pieces in place. So we couldn't be more excited.
And there's always that misconception that in order to get great care, you have to go off island. And with all of these improvements, the staff that we have at RUMC, that you have on the surgical, that clearly is not the case.
No, it clearly is not the case. There's almost nothing in Manhattan that we can't do.
It's a great way to end it. It's a great way to end it. My thanks to Dr. Messina and Dr. Harris for joining me and for all you're doing to help keep the community healthy, and we're looking forward to the new surgical department and all the improvements that are coming up. Staten Island, Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for nearly 120 years, and you can help ensure that care continues for decades to come by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, you can visit our website at rumcsi.org and click on the donate button located on the top of the homepage, or you can call 718-818-2106. In the meantime, that just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz. Stay safe and healthy.